Hello, everyone. On behalf of the Biofeedback Federation of Europe, I would like to welcome you all to today's webinar on mindfulness as a non-pharmacological approach for migraine treatment. My name is John Bale, and I will be your moderator for this event. In today's presentation, Dr. Licia Grazzi will be discussing her clinical research on an over-medicated population group that suffers from chronic migraines. She will primarily focus on her most recent study that compares the use of a mindfulness-based behavioral treatment approach versus the traditional treatment for migraines with medication. For those of you who are not familiar with Dr. Grazzi, she's an executive neurologist at the Headache Center at the Besta Hospital in Milan, Italy. She actively collaborates with Frank Andrasik and has 30 years of experience with cognitive behavioral therapy techniques and biofeedback, although this presentation will not be discussing much in biofeedback. Now, you will have the opportunity to ask questions during this webinar, and there's two ways you can go about doing that. One is that you can either type questions into the GoToMeeting chat box, in which case someone has actually already done that. I've been discussing one little thing that popped up there. At the appropriate time, I will then ask your question on your behalf to Dr. Grazzi, and then we'll go from there. Alternatively, you can also verbally ask a question by clicking this raise hand icon. It looks like an open hand and is found on the GoToWebinar control panel on the right. That signals to us that you want to be unmuted to ask the question, and we will unmute you at the appropriate time so you can ask your question directly. All right, now, no more need for my small little introduction. Let's go on with Dr. Grazzi's webinar on mindfulness as a non-pharmacological approach for migraine treatment. So, Dr. Grazzi, I'm going to make you the presenter like we did before. A small little window is going to appear, and you just click the Show My Screen button to accept.
Okay, thank you for this kind presentation, and hello to everyone. I hope that your morning is going well, is starting well with this presentation.
Hold on, Licia, you just have to click the Show My Screen button that will be on the little window so we can see your computer. There we go. Perfect.
Perfect. Can you see the slides?
Yes, we can see the slides, and you can just maximize the screen so we can see this full slide if that's possible.
Perfect. 1 second. What about this?
Excellent. Thank you. You're good to go.
Okay. Thank you. My colleague Carlotta Bonfa and John Bale know that I am not a very expert in technology, and I will try to do my best. Thank you to all of you for coming, and sorry for my English. I'm Italian, and my English is not always perfect, but in this case too, I will try to do my best. If you need to do some question, you can tell me that, and we will do a very brief break in the middle of the presentation, so if you have some doubt or some question to do, we can use that time. As John told you before, I am a neurologist at the Besta Institute in Milan, in Italy, and the most part of my job is to take care of patients with migraine and different forms of headache. In particular, in the last years, we are working in the most part of time with patients who has problem with chronic form of migraine and medication overuse. So generally, we have for them different options for migraine prophylaxis and so on. But it was I was younger when biofeedback and behavioral treatments started to be more common in Italy too, and we started to use them for treating patients with migraine, episodic forms, and also for chronic form. What we are speaking about today, what I will present to you, is will be a small experience that we had with this problematic category of patients by using the mindfulness approach for treating them after withdrawal treatment for the medication overuse. Probably the most part of you know that in the literature there are papers who show that non-pharmacological approaches are beginning more commonly used for treating migraine and different kinds of headache. But in the most part, unfortunately for us, these non-pharmacological approaches have not been proved from the scientific point of view. Concerning behavioral therapies, on the contrary, there are several studies that can confirm their efficacy and so consistent level of evidence that can justify their use in routine care. The non-pharmacological approaches, in particular for headache treatment, have few serious side effects, are advantageous because they are congruent with patients' beliefs, and they have therapeutic effects, and they can contribute to develop a more confidence of patients with their symptoms and the management of symptoms itself. In the last decades, Frank Andrasik with his colleagues tried to explain the pathophysiology of migraine, of headache and migraine in particular, in a different way. So, from the general point of view, in the past, migraine was considered something like a pathological condition with problems in neurotransmitter or some kind of cerebral structure. In this new interpretation for the origin of this pathological condition views pain as emanating from a complex interaction of biological, psychological, and social variables. And in this paper, Frank Andrasik describes in a very elegant way the key behavioral, affective, and cognitive influences of so important in this disease, with many examples and very clear explanations. And this paper will be very helpful for us if we want to use non-pharmacological approach, in particular behavioral approach, for to explain how this kind of therapeutic approach can work with this condition. Consequently to this new idea about the pathophysiological explanation for the migraine process, the US Headache Consortium Treatment Guidelines for Prevention of Migraine recommends the behavioral interventions like electromyography, biofeedback, relaxation training, and so on, for patients with migraine as a therapy with grade A evidence. And this is based on 39 controlled trials. And in the last years, more commonly patients ask for having treatment which are not pharmacological, but they ask for alternative treatment modalities for headache, such as mind-body therapies, yoga, meditation, and so on. And it's only very recently that mindfulness and meditation started to be a specific treatment for this kind of patients. We know that there are many chronic pain disorders resistant to treatments aimed to eliminate the sensory component component of pain, to increase focus on reducing suffering by altering emotional and evaluative components of pain. We know that these kind of components are so important for patients to manage their pain. The mindfulness practice aims to focus attention on present experience and to reduce evaluative and affective response. The mindfulness practice origins are in the 80s by the work of John Kabat-Zinn. John Kabat-Zinn started to use mindfulness for pain patients and for other different applications of pain of patients. I'm sorry because this slide is not very good done, but the definition of Kabat-Zinn of mindfulness was a way of paying attention on purpose at the present moment and not judgmentally, without any judges, by developing acceptance, attention, consciousness, and openness. This practice can create the opportunity to respond skillfully rather than react automatically and habitually. A mindful approach can help to reduce the tendency of the mind to exacerbate negative emotional states. So if we observe this definition from John Kabat-Zinn, we can consider that we have in our hands a very powerful method for improving our possibility to manage pain. And the researchers started to use and to study if the mindfulness practice could be useful to reduce or in some way to change some mental processes. In particular, John Kabat-Zinn organized this mindfulness-based stress reduction, and this is a method, an intervention that follows a standardized 8 weeks protocol involving small groups of patients and subjects who have been instructed by certified people. The mindfulness can be taught by a daily program for every participant, and this method has demonstrated measurable neurological changes post-intervention, in particular in the studies of Salmons and Richard Davidson. There are studies, moreover, there are studies which have demonstrated beneficial effects of mindfulness-based interventions for acute and chronic pain, and in particular for the affective and emotional components of pain. And these components are so important to modulate our reaction to pain. What mindfulness can be helpful, in which way? To emphasize our non-judgmental attitude to our present moment experience. We know that generally we are always involved to organize and to establish some judgment concerning everything there is, everything that we have around to us. So this is a very different behavior. The non-judgmental attitude is very important to take a break from our reality and to think about what we are doing at that moment. The mindfulness practice may favor changes in pain tolerance in this sense, and also in pain intensity ratings, and has the purpose to teaching the individuals how to maintain focus on a stimulus while simultaneously allowing intruding thoughts and feelings to be acknowledged but not judged. In our mind, we have a lot of feelings and thoughts who are which are not helpful for our health. And the practice of mindfulness can help us to be very focused on the reality without having any problems with these intruding feelings. Another definition, mindfulness as an exploration of the biological mechanism of these treatments, and this exploration may increase our ability to treat pain disorders by increasing our understanding of endogenous pain regulation. So in this sense, all the research that had been done on this practice has been very helpful for us to understand some kind of circuits which are involved in our pain regulation. There are functional imaging studies which have been developed to understand much better the mechanism involved during the practice of mindfulness. For example, a reduced activation in specific cerebral areas as amygdala, hippocampus, and so on, or increased activation in other cerebral areas. There are very elegant studies which can help us to understand much better what can happen during a mindfulness practice process. Mindfulness has been used for stressful reduction, for pain, but not so often to explore its efficacy for chronic migraine. There are just few papers published in the last year where the problems of chronic pain and the mindfulness treatment has been in some way has been developed, and they are very encouraging. The data are very interesting, and in this sense we decided to try to include the mindfulness practice for treatment in the treatment of our patients. At this point, guys, we are also in the middle of the presentation, and we are closing with the theoric part of that, and we are introducing the clinical experience that we have done at the Besta Institute. So if you want to have a break to do some questions or something like that, we can do that now.
Perfect. So just a quick little moment. If anyone has any questions currently and you'd like to ask them to Dr. Grazzi, you can either type them into the questions box found in the GoToWebinar control panel, or if you want, you can use the raise hand icon to signal to us that you want to verbally ask a question. We'll give you a moment, but otherwise there's going to be another questions period at the end of the presentation. So let's just wait 10 seconds to see if anyone has something to ask. And thus far, it looks like there's no questions coming in. I think everyone's excited to get to the full part of the presentation with your study and your experience. Okay, let me just one more check. I think you're good to go. Please continue, Dr. Grazzi.
Okay, perfect. Thank you so much. 3 years ago, 2 years ago, almost 3, yes. The time is so fast, and we decided to include the mindfulness practice in the multidisciplinary program that we use for patients who come to our hospital for chronic migraine with medication overuse. You know that this category of patient is very hard. They are very difficult to treat. They arrive with a very long history of migraine. They have tried a lot of medication for prophylaxis, and generally they are using many symptomatics for aborting their attacks. So what we do with these patients, and generally is this, the protocol is very similar all over the world, is to try to detox these patients from the symptomatic medication, and then to introduce them to a multidisciplinary program which include pharmacological prophylaxis, psychotherapy if needed, behavioral approach, and physical therapy, just to increase the patient's functioning and to enable them to return to gainful employment, to return to a better level of recreational and social activity. You know that these patients are so have a lot of disability from their condition, so they are not very confident that you can do something for them. And in this case, for concerning the behavioral approach, we decided to use, instead of biofeedback and relaxation, we decided to use the mindfulness practice, which could modify their propensity to use analgesics. And in this case, we followed the patient for almost 1 year. We include in the program physical activity that is very important for them, for improving tolerance of pain, for improving the muscle tonicity, and so this part is very important in our program. And we treated almost 20 patients. They were female patients. You know, you probably know that migraine are, for the most part, female patients. And they tried to use mindfulness with us every week and to do some home exercises too. And we had very encouraging results with these patients, who decreased very significantly after 1 year their frequency of migraine, in the sense of days of migraine per month, and more important, their medication intake per month, and with a very low relapses rate. So after this first and encouraging experience, we decided to do something a little bit better. So to compare two different kinds of approach for patients with chronic migraine with medication overuse after withdrawal. And we followed the patients for 6 months and up to 12 months. This study was performed because we wanted to investigate if mindfulness was feasible and safe for this patient, if mindfulness could induce a decrease in frequency and in medication intake for our patients, and if mindfulness was able to change disability and quality of life in this so problematic category of patients after the withdrawal. We treated 44 patients suffering from chronic migraine with medication overuse. The diagnosis was made according to the IHS criteria. The patients were treated with a withdrawal program, and it was performed in a day hospital setting. After withdrawal, patients were given 2 different modalities of treatment for the prophylaxis. one group was treated by traditional pharmacological treatment. A second group was treated by mindfulness practice for prophylaxis. Unfortunately, we didn't do any randomization in this case because the patients who were involved in mindfulness practice were patients who live in the area of our city. And so for this reason it was problematic. As the sessions were weekly, it was problematic to propose to patients very far from our city, from Milan, to be included in this group for coming every week for the session. So we had 22 patients for each group. They were very similar for general characteristics and history of headaches and medication consumption. Physical activity was included and indicated in this protocol too. Some kind of lifestyle modifications were suggested when needed. Patients were followed with the check every 3 months and up to 12 months after withdrawal. And we performed some psychological tests for disability as MIDAS, age IT6, for anxiety, and for depression we used the back inventory. And all these analyses were performed before treatment and at every follow-up that we performed. For the pharmacological treatment, patients were treated by different options, traditional for migraine prophylaxis, and the pharmacological treatment was decided according to the clinical history of every patient, physical and psychological characteristics, and presence of possible comorbid conditions. For the mindfulness protocol, we treated patients with 6 sessions, 1 session per week, 45 minutes of guided meditation practice, and all patients were invited to practice at home at least 7-8 minutes per day. During the session, the patients were invited to close their eyes and to breathe quietly and to accept any sensation at the moment without any kind of judgment. We didn't use the MBSR used by John Kabat-Zinn. We used a protocol very similar but not the same. So we prefer to have 6 sessions, 45 minutes for our patients. We were very surprised when at 6 months, we were not very surprised when at 6 months we had good and significant results from the group which was submitted to the pharmacological treatment. A significant decrease in days of migraine per month and corresponded to a significant decrease of medication intake per month. A dramatic decrease in disability because patients were going much better. We do not have so big change in anxiety and depression. They are not very significant, but they are not so bad in our population of patients. The depression and the quality of life indexes went better without reaching significant results. But it was encouraging. It was surprising for us to look at the results that we obtained from the group submitted to the behavioral approach with mindfulness practice. They improved significantly in terms of frequency and medication intake per month and in disability scores. And also, although not significantly, in back depression inventory and in quality of life too. So these patients were much better, went very well, also if they did not use any pharmacological prophylaxis for their migraine after their withdrawal. As you can see here, there is also a much better behavior in group of mindfulness, because the group of patients trained by mindfulness did not increase in medication at 6 months at the group of pharmacological treatment. Probably the reason, a possible explanation could be that patients treated by behavioral therapy, by mindfulness, were much better educated at the end to manage their pain without using necessarily a pharmacological compound. And this is a very good result in our mind. These are the graphs related concerning the results of the tests that we did, the back depression inventory, the STI trait inventory, and the age IT6, and the MIDAS score, and the MIDAS questionnaire for the disability. The approach with mindfulness seems to be safe, effective for patients at 6 months follow-up after withdrawal. The patients reported a very significant benefit at the end of the program, an increase in quality of life, a decrease in disability level. Unfortunately, we did not have any randomization for this study, and the number of subjects is very limited for this study, and we hope to do better in the future. But we obtained a very good results in this first experience with this category of patients. We know that, and you probably know much better than me, that behavioral techniques, methods, and their efficacy have been proven by different authors and researchers in the past in the literature, and there are researchers like Irene Tracy who try to give explanation of the efficacy of scientific and biological explanation of the benefit of these methods by working with the functional MRI. So there are also meta-analytic reviews that have summarized the empirical evidence, examining how much these behavioral approaches can be effective. There are many advantages that we can have by using behavioral options. Long-term efficacy, there are no side effects, they can be used alone or combined with other therapies. They are very easy to perform if the patients are very young. And the patients, this is a very important thing, are directly involved in the therapeutic program. And so they can learn to be much more conscious about their problems and about their therapeutic option. And also, behavioral options can be very helpful to avoid the early onset of medication overuse and to reduce the relapses of overuse in patients already treated by withdrawal. There are not so many papers who compare directly behavioral and pharmacological treatments, but there are studies which are evolving with comparison in this sense. What we can do, what we know up to now is that the combination of pharmacological and non-pharmacological treatment has been shown to be superior to each individually and appear to maximize long-term therapeutic benefit. As we can see in this paper, very old paper that we performed many years ago in collaboration with Frank Andrasik, where two groups of chronic migraine with medication overuse were treated by two different modalities. For one group, just pharmacological treatment. For another group, pharmacological treatment with added to behavioral treatment. And patients who were treated by the combined treatment obtained a good benefit, a significant benefit, prolonged over time until the 3 years follow. And this is very significant and very important for patients with a condition of chronic pain. So through the education and cognitive behavioral therapies, all patients can be taught ways to modify thoughts, feelings, and behaviors around medication taking and headache management strategies, and also management of the physiological effects of stress and the prodromal symptoms of headache attacks through techniques as relaxation, biofeedback, or meditation. In this sense, patients can learn to avoid the compulsion between pain and medication, And the compulsion, this kind of compulsion, is very dangerous, and it is a big risk to arrive to develop a medication overuse, headache, and a chronic situation of pain. Migraine and other kinds of headache are probably, yes, biobehavioral disorders, and in this sense, more than a painful condition residing in receptor physiology, and more aptly recognize it as a condition wherein physiology, cognition, and behavior are interconnected. And for this reason, a simple pharmacological approach can be not enough. So, primary headaches can be best understood and managed from a biopsychosocial perspective. In this sense, the paper presented by Frank Andrasik has been so helpful for us to understand much better the reasons because our patients are so suffering and the ways to help them more effectively. In fact, because migraine and chronic migraine with medication overuse are complex combinations of biological, behavioral, and emotional components, the most effective treatment strategies include a combination of pharmacological and non-pharmacological approaches. Probably, if we go ahead to use just pharmacological treatment for this kind of patient, and generally for patients with chronic pain condition, we do not have treatment so effective. Probably we need to add non-pharmacological approaches to traditional pharmacological treatment. In our experience, the results are preliminary, but the mindfulness can be considered helpful as non-pharmacological option for this patient to improve emotion regulation, decrease pain catastrophizing, increase pain acceptance. In this sense, patients with chronic pain, you probably know that they have this kind of catastrophizing feeling, and mindfulness can help them to face up and to reduce this feeling. And our patients in these slides arrived to 6 months follow-up. It was interesting to follow them until 1 year follow-up. And we are completing our follow-up during these last days. And what we can say is that all the patients in mindfulness group maintain their significant benefit at 12 years. So I hope that if everything was fine today, we can have another occasion, another opportunity. I can have another opportunity to show to you the data concerning the last long follow-up at 12 months. Thank you for your attention.
Thank you very much, Dr. Grazzi. I would actually be really happy to give you that chance to show up the follow-up data some other time. Thank you, everyone who's been paying attention. As we said earlier, there is another chance to ask any questions to Dr. Grazzi. And so let me just make myself the presenter for a moment. Show my screen. So as a quick reminder, if you'd like to ask a question, you can do so two ways. You can either type your question into the question box of the GoToWebinar control panel, and then I'll ask the question in a moment. Alternatively, if you want to verbally ask a question to her, you can just click this raise hand icon that's found on the side of the GoToWebinar control panel, and then I'll unmute you, and you can verbally ask that question. While I'm giving everyone a moment to write down these questions or decide if they have anything to ask, I just want to let everyone know that BFE is definitely releasing its mindfulness suite right now, and we're just want to let you know that this is a potential tool that you can add to your clinical toolkit. BFE created this software package in collaboration with Ina Kazan, writer of the Clinical Handbook of Biofeedback, a step-by-step guide for training and practice of mindfulness. That does currently work with the Biograph Affinity software and thought technology equipment. It comes with everything you might need for assessing and training an individual using biofeedback and a mindfulness perspective. So normal stress profiles, relaxation profiles, resonant frequency evaluation, and training. And it comes with many Excel reports for analyzing that data. Included are also some of Dr. Kazan's own relaxation scripts, and every part of this software links back to her book in exact sections. One last little note about this is that, utility aside, it's also actually designed to look quite nice, so no more of that clunky, ugly other software packages. It actually looks beautiful, and although it doesn't necessarily change how treatment works, people like to look at this more and they feel more convinced to buy it. If anyone's interested in learning more about this mindfulness suite, we actually have a free open house session later this week hosted by myself. It's at 10 a.m. Eastern Time for Canada, US, or 4 p.m. for France, Germany, and Italy, and you can sign up for that at bfe.org. One last little remark before we get to the last questions. Other BFE online events upcoming are 2 Grand Round sessions hosted by Linda Walker. Anyone who has ever had a session led by her absolutely loves her. These sessions are for practical applications of HRV, in case you want to ask a clinical expert advice on a heart rate variability clinical case you currently have. You can attend this. And then the other session is for Z-scores, so neurofeedback normative-based training. As one little final remark, if any of you are currently looking for introductory classes on neurofeedback, we have an upcoming class also taught by Linda Walker on understanding the raw EEG. It's an excellent, excellent framework for anyone getting started in the neurofeedback field. All right, so let's have a quick look at the questions. I see there's one little comment coming in. From Gerard, one question, Dr. Grazzi, is, were the participant stress levels measured before the project started?
The first part of the question, I couldn't hear you. I'm sorry. I am very close to the bathroom, and there are men at work here, so
that's okay.
Sometimes
That's okay. You're very unlucky. We heard some of the construction actually happening behind you. So Gerard's question is, were the participants' stress levels measured before the project started?
No. Okay. No, we didn't measure any stress level before the protocol starting. We didn't use that.
Mm-hmm. Okay. I actually have a question for you. Have you ever considered the option of using biofeedback with those individuals as well?
John, we use biofeedback in the most part of our clinical practice many years ago. Mm-hmm. The problems were so many because up to now we do not have any room where can we use biofeedback, mm-hmm. and At the same time, yes, we didn't have any equipment for using biofeedback at the hospital because many things changing in the last years. For this reason, when we didn't have the possibility to use that behavioral approach, we tried to use different kinds of behavioral approach because we decided to go ahead with this practice, but we didn't have the conditions here to use biofeedback. And that was the principal reason because we didn't, we stopped to use biofeedback. But I have to say that I think that biofeedback is very important, can be very important for patients, for understanding some changes that patients can realize in some functioning of their physiological functions. But also, I think that for some reason, to be more conscious also by using different kinds of techniques without using just only the instrument can be very helpful for patient itself.
Okay,
That's my
a combination of treatment tools then. All right.
Yeah.
We have some...
Yeah, I think that, biofeedback is very helpful for patients to verify if they are going well or not. But the combination of two different things can be more helpful for patients.
All right. Thank you, Dr. Grazzi. We have some people saying thank you very much for your presentation. They found it very useful and interesting.
Thank you. Thank you for your attention. I appreciate it so much. Thank you so much.
All right. Does anyone else have any last-minute questions? Let me just check. I'll wait for those. No one has their hand raised, so that's good.
Okay.
Nope. Okay. So,
okay.
I don't think anyone else is asking more questions, so I'd just like to say...
Have a nice day.
Yeah, thank you very much, everyone, for attending. And again, thank you very much, Dr. Grazzi.
Thank you, John, for everything.
No problem.
Thank you, all of you.
If you have any last-minute questions after the end of this presentation, please feel free to shoot those questions to shop@bfe.org, or if you want any additional information about the online classes that I mentioned or the Mindfulness Suite, please shoot us an email there or check out our website, bfe.org. As always, you can find us at bfe.org, bfe.org/buy. We'd also like to point out the Besta Neurological Institute's website, and we'd also like to thank our sponsor, Thought Technology. So, again, everyone, thank you for attending. Thank you, Dr. Grazzi, and we will hopefully see you soon.
You.
Hold on, one last
Have
question.
Have a nice day.
Yeah, thank you. And one last question. The session will be shared with everyone as a recording, so you will be able to look at this at a later time as well. That's an answer to Lena's question. All right, so thank you very much, everyone, and
bye-bye.
Have a good day. Bye-bye.
You too.